Hello, my name is Andrew Nowak. I'm an assistant professor of pediatric infectious disease at Children's Hospital of Pittsburgh, of UPMC in Pittsburgh, Pennsylvania. Today I'm going to be speaking to you about common pediatric infections. I have four objectives today. The first is to define a few pharmacology principles and how these impact treatment of common pediatric infections. With all of the pediatric infections we're going to discuss today, I want to review their microbiology. And I then want to review evidence that exists for optimizing therapy of common illnesses, focusing on current guidelines. And then finally, I'd like to discuss, as the focus of this lecture, common cases of challenging pediatric infections and best choices for therapy and management for all of them along the way. I just want to note that pharmacology and making good antibiotic choices are natural things that go together, and that not to be fearful of pharmacology. Knowing a little bit goes a long way here. We'll talk about several themes of pharmacology today, specifically combining our knowledge of organisms that cause our infections with specific drug choices. Some examples of this include beta-lactamase production in Haemophilus influenza, which significantly influences choice of antibiotic for some of our common upper respiratory infections such as sinusitis and otitis media. I want to talk a little bit about penicillin binding protein changes. This is an example that we see in Streptococcus pneumoniae, where we can overcome it with high-dose penicillin therapy, as well as MRSA, methicillin-resistant Staphylococcus aureus, where the penicillin binding protein change makes it resistant to even cephalosporins, and we have to shift to a completely different class of antibiotic. And other examples such as macrolide resistance in group A streptococci. And I want to start out with a quote from the movies. They're more like guidelines. All of the infections that we'll discuss today have recent guideline updates that are either from the American Academy of Pediatrics or the Infectious Disease Society of America, or both. Many of them are joint guidelines between the two societies. So many of the recommendations that I'll make are supported by recommendations of these organizations. So I want to start and execute this talk by using cases. So we'll start with the first case that I'll title Combinations Are Great. And this would be an 11-month-old boy coming into the emergency department at your institution with a fever to 39.3 rectally. This is a child with 3 days of cold symptoms and impressive amounts of nasal drainage. We're all familiar with this in pediatrics and in family medicine. And this child is crying hard and pulling at his right ear. So he's kind enough to indicate where you should look. And when you're doing his examination, you're able to assess an otitis media. When you look in the right ear, you see this very classic picture of acute otitis media, a bulging tympanic membrane that on insufflation does not move at all, that clearly is bulging because of a large amount of purulent fluid behind it. It's a great day when you can see this picture easily. When we think about antibiotic choice here, I think this is one of the key decisions that you need to make in an outpatient or an inpatient setting for a child. And so we start with the microbiology, as I said. The microbiology of acute otitis media has been fixed for some time. The primary pathogens are all bacteria, Streptococcus pneumoniae, Haemophilus influenza, and Moraxella catarrhalis. But there's some significant differences in mechanism of resistance here that will influence somewhat our choice of antibiotics. Streptococcus pneumoniae alters its penicillin binding protein that produces low-level resistance, so increases in MICs of penicillin from 0.5 to 1 or 1 to 2 up to 8. And this is something we can overcome with more drug. Whereas with Haemophilus influenza and Moraxella catarrhalis, the production of a beta-lactamase raises the MIC unacceptably high, and we really can only overcome this with inhibition of the beta-lactamase. And while Haemophilus influenza is uncommon in its beta-lactamase production, it is becoming more frequent, and Haemophilus influenza overall is the increasing cause of ear disease since the introduction of PCV7 and then PCV13. So we can rely on a guideline here. This is a recent practice guideline on acute otitis media from the American Academy of Pediatrics, and you can see the reference below. And you can see the table from this reference, which is the recommendation of whether you think about antibiotic therapy or observation with these cases. And I want to highlight here that additional observation remains an option in an older child who has bilateral disease without otorrhea or unilateral disease, and in a younger child who has unilateral disease without otorrhea, as long as we're not looking at a child who has severe symptoms. So when you see otorrhea or you see severe symptoms such as fever, greater than 39, persistent otalgia, or uncertain access, you would want to err on the side of antibiotic therapy for these children. And as you can see here, in the younger child, there's more pressing need for antibiotic therapy. AAP recommendations for initial therapy have not changed for some time, and you can see here that they highlight amoxicillin as a first-line therapy or amoxicillin clav. I will say that with the increasing amount of Haemophilus influenza that we're seeing and the increasing production of beta-lactamases, amoxiclav is a very acceptable first-line therapy and what I recommend to our residents as well. Alternative treatments I generally recommend against, only if there's penicillin allergy. I don't think that oral cephalosporins, despite their popularity, have any role in the initial treatment of acute otitis media. When we look at failure therapy, I want to emphasize here that amoxicillin clavulanic acid, if you have failure after 48 to 72 hours, is your mainstay drug. And ceftriaxone is a very important component both of recommended first-line treatment as well as alternatives for allergy or failure of a second antibiotic. And when you get into very complicated cases, I think consulting specialists are a reasonable option. Is there data behind this? There is excellent data, and I'm going to refer you to a review in 2009 by Ron Dagan that looks at the connection between antibiotic levels, microorganisms, and clearance of infection. This is a complicated table, so stay with me, and it depicts Haemophilus influenza in light gray, non-susceptible strep pneumo in medium gray, and susceptible strep pneumo in black. And it depicts, for each of the antibiotics listed here on the x-axis, the percent persistence of pathogen on the y-axis. So very effective antibiotics will have very little persistence. And as you can see here in this bar graph that shows organisms and their persistence with each antibiotic, that we have some commonly used antibiotics like amoxicillin and ceftonir, which are pretty effective, although I'll point out to you that penicillin non-susceptible strep pneumo have a very significant failure rate with ceftonir that they do not have with regular amoxicillin, even at low dose. And I will point out also that ceftriaxone for 3 days is our standard salvage therapy, but when you look at amoxicillin clav at 90 per kilo at high dose, it's as effective as ceftriaxone. So I would refer you to the fact that amoxicillin clavulanate is a very, very acceptable therapy to start as well as to back up with when you have a child with ear disease, and that there's no need, based on this data, to explore the use of cephalosporin. So that case demonstrates guidelines on acute otitis media. I want to use the case to talk about penicillin binding protein, getting down with PBP, as I'd say, to look at a different site of infection. So this is a 1-year-old boy who comes into your urgent care facility with fever, again, much like the previous case, 3 days of cold symptoms with lots of nasal drainage and low-grade temps, but now has much higher fever and is also tachypnic. His exam is normal except for crackles over the right lung, and when you get a chest film, you see this lovely round pneumonia that you can see here, very well circumscribed, that's probably in one of the posterior segments. You can see on this film that it's clearly a posterior segment, probably of the right upper lobe. So the radiology read agrees with you. This is a round pneumonia in the right side. And when we think about what could cause this, in this older child, you can see here that when you look in the bacteria column, which this is very likely to be with a round pneumonia, strep pneumo really dominates the epidemiology. So strep pneumo is a great choice as the prime cause of bacterial pneumonia in every child other than a neonate. And if you're looking at a neonate with pneumonia, I think you really want to be consulting with a neonatologist or other specialist. Viral pneumonia, I will emphasize, is still much more common in most of these age groups, whether it's parainfluenza, adeno, or influenza viruses, certainly in season. When we look at what's causing pneumonia in children, there's an excellent study that's now about 15 years old from Peds IDJ that shows outpatient and inpatient causes of pneumonia. And you can see that no cause being able to be identified is common in both of these studies, whereas bacterial pathogens are more common in inpatients than outpatients. Viruses are quite common in outpatients, but bacteria-viral combinations are actually very common in inpatients. And bacterial-viral combinations probably reflect bacterial superinfection of an antecedent viral infection predisposing these patients to admission. So as you can see here, when you have a hospitalized patient, I would seriously consider bacterial therapy on a regular basis. So bacterial pneumonia, much more common in hospitalized children. That study from 1999 was confirmed in a 2004 study as well. And the high temperature after admission as well as pleural effusion are also strongly associated with isolating a bacteria. In the 2004 study, mycoplasma was much more common than we had previously seen in older children or in younger children, but ambulatory patients tended to improve even if they were not on an effective drug for mycoplasma, raising the question of how much mycoplasma really contributes to disease in the younger children. Geography and season for pneumonia are important as well. Obviously, RSV begins in the fall and recedes by late spring, although that changes in different parts of the country. And influenza season is important for any practitioner to understand. We do see the most pneumococcal disease in winter as well. Geographic associations are also quite important. Histoplasmosis is associated with disease in the Midwest, and MRSA pneumonia is seen in very isolated spots, more common in some series in Texas and in Chicago than in our area of the country, certainly. And certainly with vaccination, we have seen an absence of Hib and a decreased rate of pneumonia in less than 1-year-olds with the administration of PCV7 and then 13. Pediatric pneumonia under 5 years old really calls for no need for cephalosporins, therefore, because pneumococcus doesn't require a cephalosporin or a beta-lactamase inhibitor. It doesn't make beta-lactamase, and so its low-level resistance can be overcome with more drug. So high-dose amoxicillin, 80 to 90 milligrams per kilo, gives you a great peak serum level that's enough to overcome penicillin intermediate strains very well. It's narrow focus and narrow spectrum of activity, and so it is by far and away the number one drug you should think of. And this is confirmed in a recent guideline from 2011 from the Infectious Disease Society of America that was also worked out by members of the AAP. And you can see here for community-acquired pneumonia in the outpatient setting, amoxicillin is really the primary drug. Then for atypical pneumonia, azithromycin would work well too. And amoxicillin is another confirmed choice for the greater than 5-year-old crowd as well. So amoxicillin really should be your initial therapy for many of these different situations. When we look at inpatients, we would emphasize that ampicillin is perfectly acceptable. And if you have an unimmunized child where you might see Hib, you could use a cephalosporin. But most evidence-based guidelines will emphasize that ampicillin or penicillin G are the appropriate therapies for an inpatient with bacterial disease, and azithromycin should be reserved only for those with atypical pneumonia. So that really emphasizes the role of amoxicillin both in ear disease and community-acquired pneumonia. And I wanted to go over a case where there's some uncertainty about whether cephalosporins should be used that's been raised more recently. And this is a common case that I'll title, You Say Tomato, I Say Cephalosporin. And it's an 8-year-old boy coming into your office with a fever to 39.3. This child does not have URI symptoms except for pharyngitis, but also has some headache and mild abdominal pain. And when you look in his throat, he has beautiful palatal petechiae, swollen tonsils, and uveitis with a lot of erythema that's very consistent with group A strep disease. So a rapid strep when done in the office would be very reliable here, and it would be positive for group A strep. And when we think about antibiotic choice here, it really remains penicillin or amoxicillin. I do want to mention that there's been a number of publications in the past 10 to 15 years, a small but vocal minority of pediatric infectious disease folks who feel that treatment failures are too common with penicillin, with high rates of failure, quoted as high as 30%. But I'd say that many of those assertions have not been confirmed in controlled studies, and there's no really reports of antibiotic resistance in group A strep. So when we look for our guideline again, there's a great guideline from 2012 from the Infectious Disease Society of America for the treatment of strep pharyngitis. And you can see here they do a very nice job in the guideline of emphasizing features that suggest group A strep pharyngitis, and that includes perfect features of the child we're seeing. Sudden onset of pharyngitis in a school-aged child with fever, tonsillopharyngeal inflammation and patchy exudates are common. Palatal petechiae are actually quite helpful, whereas conjunctivitis, coryza, or cough, other URI symptoms, hoarseness, or any evidence of ulcerative stomatitis argues strongly against group A strep. And the guideline, as you can see here, is very specific. Penicillins are the backbone of therapy here, and the guideline recommends the use of cephalosporins only in individuals with penicillin allergy. And I want to emphasize that once-daily therapy with amoxicillin is a very strong and pertinent part of this guideline, 50 milligrams per kilo once daily with a max of 1 gram. You can use a twice-daily dosing, but we use the once-daily dosing routinely. It's very effective, and it's very easy for compliance. That's a quick detour into pharyngitis and pharyngeal disease. I want to move over into a much more common problem in the last 10 to 15 years that I'll title double boils are trouble. And this is a common experience in pediatric and family medicine offices. A 1-year-old boy brought in by his mother to a local PCP office with a spider bite. And the mother notes that the spider bite occurred on his left buttock 3 days ago. That was a big, hard red pimple, and this red pimple is getting bigger, getting redder, and turning into a head. And as you see on exam here, you can see in this area a nice white head with what would be a very firm, indurated subcutaneous mass of tissue below. So this spider bite is, of course, an abscess that you drain in the office with copious purulent fluid, and very unsurprisingly, given the epidemic of MRSA skin disease in children in the United States, it grows of methicillin-resistant Staph aureus. And the antibiotic choice here can be quite confusing. You have a number of options. Clindamycin and Bactrim or trimethoprim sulfamethoxazole are the two most common choices. Clindamycin gets group A strep too, and when it can be used, is a really effective medicine. The con of this is that there's a bit of resistance, and the liquid preparation of clindamycin is not palatable at all. In fact, for younger children, I'll often prescribe them the sprinkles from a capsule to be distributed on pudding or some other way of conveying it, as the liquid preparation is really nasty. Bactrim is a great drug, TMP sulfa. It's virtually all staff are sensitive to it, but it does miss group A strep disease, and in some older children, the question of group A strep is an important one. And there are some questions about its role in invasive staphylococcal disease. I do use doxycycline quite frequently in the older crowd since there's very little resistance, but you have to be carefully counsel about adverse effects. And though linezolid has actually been studied, it's far too expensive and I don't think is a reasonable choice for most kids. We do have a good guideline to fall back on here. And again, another IDSA guideline that was worked on by many folks from my Society of the American Academy of Pediatrics as well. And when we talk about management, I want to emphasize a lesson that we learned in the 60s and I think forgot a little bit, and probably learned in the 1750s and forgot a bit, that for simple abscesses and boils, incision and drainage alone is likely to be adequate. And the additional data needed to further define the role of antibiotics, if any, is really lacking. So when you have a small, simple abscess or boil, once it's drained, it's almost completely treated. And I want to just emphasize that the few situations where antimicrobial therapy would definitely be recommended are certainly severe or extensive disease involving multiple sites or signs of systemic illness, particularly in a child, significant fever. Any immune-suppressed patient should be certainly looked at for antibiotic therapy. Extremes of age, abscess in a difficult area such as the face, hand, or genitalia, septic phlebitis should speak for itself, or a lack of response to incision and drainage, although I'll say the lack of response is typically an inadequate incision and drainage. When you have outpatients with purulent cellulitis, empiric therapy is recommended. Empiric therapy for beta hemolytic strep is likely to be unnecessary when you have a significant abscess. Beta strep is much more likely to cause simple cellulitis. And 5 to 10 days of therapy is recommended, but there's really no evidence for what course you should provide and should probably be individualized per practitioner as well as patient. This is some of the antibiotic choices, as I mentioned before, with doses for adults and pediatric patients. As you can see, a lot of different options are available. For small abscesses which are well drained, then I'd say no antibiotics are generally needed. Larger abscesses, in many studies, will quote a figure of greater than 5 centimeters, probably do deserve some antibiotics. But again, I cannot emphasize enough, a good incision and drainage is key here, sedation if necessary in the smaller child with aggressive palpation, and some exploration with a blunt probe to break up septation. That's really what your patient needs, as well as good warm compresses to promote drainage afterwards and packing. That really addresses community-acquired MRSA, but I want to move on to another very common pediatric infection that you're going to see routinely if you see any pediatric patient. This would be another 1-year-old, but now a 1-year-old girl coming into your office with fever. And this is a child with 3 days of fever to 102, taken rectally, but with no other signs, no rashes, no respiratory symptoms, or anything localizing to a specific organ system. And knowing literature and knowing that it's a cheap and effective test, you send a urinalysis, and there's lots of pyuria and lots of bacteria suggesting a diagnosis of urinary tract infection. So you diagnose her with UTI and send her urine sample and get a sensitive E. coli strain coming back. The microbiology here is useful, and I list microbiology starting with E. coli and then other Enterobacteriaceae, but really this list should be all E. coli with the other options off the bottom of the slide. E. coli really dominates the microbiology of urinary tract infection in children, and I think once you've considered effective therapy for Escherichia coli, you really do not need to consider significant therapy for others. You do need to follow culture results clearly, but I would base your initial treatment algorithms on what your E. coli looks like in your community. Pediatric UTI, I will emphasize, has become the most common serious bacterial infection since the institution of Haemophilus influenza type B vaccination and then pneumococcal conjugate vaccine, first pneumococcal conjugate vaccine 7 and now pneumococcal conjugate vaccine 13. It's also the most common and really the only bacterial superinfection we see in RSV-positive children when you think about your children in the inpatient setting. Really extremely common. Females less than 5 years old are a huge risk group among children, whites greater than other races, and no fever without source is a predictor. When you look at our emergency department here at Children's Hospital of Pittsburgh, and you look at a child, a female coming in, a white female under the age of 5 with fever without source, the risk of a UTI in those patients is in the double digits, which is incredible when you consider how often viral syndromes can cause fever in children. And certainly, if you have children in your practice who have urinary tract abnormalities, as pointed out here, vesicoureteral reflux, any sort of a structural abnormality such as hydronephrosis, duplicate ureter, or the like, you really need to think about UTI. And in children with bladder dysfunction, neurogenic bladder from cerebral palsy or other injuries, you need to think about it first in a child with fever. Fortunately, we have some excellent information from the American Academy of Pediatrics quite recently. This is the clinical UTI guideline that was published in 2011 in the journal Pediatrics that really guides our management of initial UTI in febrile infants and children from 2 to 24 months. I'll emphasize on this page the 2 to 24 month nature of this guideline. It's really not intended to address management of UTI in an adolescent female, for example, and that's where I would really rely on your typical guidelines for adults, where you can use shorter therapy as your patients can indicate that they have symptoms, and often you're dealing with cystitis and not upper tract disease. Children in the age group 2 to 24 months very frequently suffer from pyelonephritis as a complication of their UTI, and as a result, our management's a bit more aggressive than the older child or the adolescent. So when we look at management and look at action statements here, you certainly, when you're initiating treatment, should base the choice of the route of administration on practical stuff. So initiating treatment orally or parenterally is equally efficacious, but it's quite common in children who are presenting with urinary tract infection that they will present significantly dehydrated or unable to tolerate PO. So initial therapy parenterally, including an IM dose of ceftriaxone, is quite reasonable in these children. And clinicians should base your initial choice of agent on local sensitivity patterns if available, and then once the final identification of the pathogen is obtained, should adjust your antibiotic coverage. And as you can see in the next action state highlighted on the right here, 7 to 14 days of therapy as duration for these infections is quite common. And this does address the fact that upper tract disease is a bit more common in children. When we think about IV therapy in children, you can see here a number of options. Ceftriaxone, I have to admit, is the one we use most commonly and our favorite. Ceftriaxone is a lovely drug for a single IM dose as starter therapy to help get a child out of an urgent care or an office who has UTI. It has a very long half-life, and the IM dosing gives you 24, even 48 hours to start therapy and review the results of the urine culture if you want to adjust therapy as time goes on. Particularly in most children, although children tolerate aminoglycosides much better than adults, I would never resort to an aminoglycoside unless you had an established risk in that child that might be necessary. And this is a usage pattern I would recommend much more typically only in an inpatient setting when you're concerned for the development of resistance. Oral therapy is an important slide here, and I want to emphasize the choices that are available to you. And this is really empiric therapy. I really can't emphasize enough that empiric therapy for urinary tract infection is going to be intentionally a little bit more broad. I will point out here that some common popular empiric therapy like cefixime is probably a little bit too broad, and so the use of trimethoprim sulfamethoxazole is quite reasonable in children with urinary tract infection. If you have a child with a UTI, Bactrim is often a very effective drug for the treatment of that child. I will mention, of course, that Stevens-Johnson syndrome and allergic rash syndromes such as erythema multiforme are of major concern to many practitioners, but those rates remain low despite the fact that we use a lot more trimethoprim sulfamethoxazole in the era of a community-acquired MRSA. And I'll also point out here that the guideline committee included specifically amoxicillin clavulanate as an initial choice of therapy, given that so many of these E. coli strains are very sensitive to antibiotic, that amoxiclav, when given orally in sufficient concentration, gets concentrated in the kidneys to such an extent that it will overcome even some intermediate strain. When you're talking about the definition of therapy in these cases, urine culture results are key to narrowing your therapy. You have to be very vigilant to make sure you monitor what comes back in these cases, and when possible, use a much narrower agent. Amoxicillin is actually quite effective alone for many E. coli strains. It is definitely a choice that you could use. It gets concentrated in the kidney such that the 8 to 10 milligrams per kilo, or 8 to 10 micrograms per milliliter peak serum level that you see for ear disease gets concentrated probably 10 to 50 times in the urine, and so you're dealing with a really tremendous amount of antibiotic in that urine. I would not be afraid to use amoxicillin in a child where you had a fully sensitive E. coli, nor would I be afraid to use Bactrim or amoxiclav. All of these options are available to you. And I will also mention in the management of these infections that the guidelines have changed in pediatrics. When we have a patient with a first urinary tract infection in this age group where there is some uncertainty, the screening with a renal ultrasound to look for any structural abnormalities is still supported, but the American Academy of Pediatrics now does not recommend a VCUG with a first urinary tract infection in these children, unless there's a significantly concerning course. So your child in this age group, 2 to 24 months, who has an initial urinary tract infection, does not need to receive a VCUG at this time. It does need to receive a screening ultrasound, but we found that the VCUG often is not significantly impactful on outcome, and as the role of antibiotic prophylaxis for children with vesicoureteral reflux is in a little bit of flux itself, we would not recommend a VCUG with the first infection. I would say that anytime you're seeing an infant who is male who has a urinary tract infection, they're always a candidate for a VCUG simply because the course and epidemiology of urinary tract infection in boys is much more tilted towards significant renal abnormality. Our next case, case 6, I titled Running, 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 because that is really how a parent dealing with this child would describe the nasal discharge from this patient. And it's an active area of concern, a very common outpatient problem. This would be a 9-year-old boy coming into your office with fever and constant nasal drainage. The main complaints that he'd have in office as he looked miserable would be 4 days of high fevers to 102. And although he might not be able to describe it well, he might give you a story, if he's well-spoken, of a lot of congestion and pressure in his sinuses, And when you do your physical examination, you would note significant tenderness over his maxillary sinuses and perhaps even frontal sinus, and impressive amounts of greenish purulent nasal discharge. You also might have a patient in this same diagnostic category who's had several days of a URI that was getting better, 6 or 7 days of such, and then a sudden worsening with an increase in fever, increase in drainage, and much worse symptoms around day 10. So any of these scenarios would naturally lead you to worry about a diagnosis of sinusitis, or more properly, acute bacterial rhinosinusitis. But making the diagnosis is very critical here. What is it that distinguishes acute bacterial rhinosinusitis, or ABR, from a simple viral upper respiratory infection? And there are 3 really key symptoms here. Viral URI is so common in our country that it's very hard to ignore the fact that the vast majority of patients coming in with nasal drainage will have a simple viral URI. But there are 3 things we recognize as very good signs for ABR. Number 1, when you're at the 10-day mark and you have persistent signs and symptoms that just have not improved at all, I think an ABR picture is very important to consider. We also recognize that there are children like the initial presenting case here where you have severe symptoms or signs of high fever greater than 39 with very bad purulent nasal discharge or facial pain in the first 3 to 4 days. So those children who become acutely ill with localizing signs to the sinuses should be considered as having acute bacterial rhinosinusitis as well. And then finally, when you have a child with an initial URI for 5 or 6 days that was initially improving and then develops worsening fever, headache, increasing in nasal discharge, similar to the second category, what some folks have described as double sickening, that is a very concerning scenario for the development of acute bacterial rhinosinusitis, and I think makes a clinical diagnosis. Once again, we're able to rely on a guideline. This is an excellent guideline from 2013 from the Infectious Disease Society of America that also, along the committee, employed several prominent pediatric experts in sinus disease, including Ellen Wald, who was a prior division chief here at Children's Hospital of Pittsburgh. I want to emphasize a flow chart first from the guideline that really emphasizes these 3 categories, as I said: persistent or not improving symptoms at greater than 10 days, severe onset of symptoms early on, or worsening or double sickening, as I had mentioned before. These are all signs that would make you concerned for an acute bacterial rhinosinusitis. And when you look at the initial management, one of the things that the guideline asks you to do is look at their risk for resistance. Risk for resistance is quite predictable. Among children, it's age less than 2 or daycare exposure, prior antibiotics within the past month or hospitalization, and then, of course, significant comorbidities or immune compromise. So really, the risk for resistance helps to guide you in whether, when you look at their resistance, whether you'll start with first-line or second-line antimicrobial therapy. And I want to review that very quickly to point that out. I also want to mention that the microbiology here, again, is going to remind you of the microbiology of otitis media, in that Streptococcus pneumoniae, Haemophilus influenza, and Moraxella catarrhalis are the most common found pathogens. And you can see here that in more recent publications, H. flu has really overtaken strep pneumo and really is among the most prominent bugs, and Moraxella is actually a little bit more common as well. And that this epidemiology looks quite similar when you compare pediatric studies with adult studies in this period of time. There's a bit higher incidence of Staph aureus in many of these studies as well. And although anaerobes are not specifically addressed in the more recent studies since 2010, I think they're a very important consideration in many of these infections in that we do a very poor job of isolating anaerobes, and they may be a key player in a number of these patients. When we think about the choice of agents, we want to be careful to know that resistance levels in young children tend to be high, as noted above, and so I would be thinking about second-line therapy in a number of children. And then importantly, if you're starting first-line medications, lack of response should be assessed carefully by communicating with the parent. When we think about first-line therapy, first-line therapy is really amoxiclav and not amoxicillin, and this is a change for pediatric practitioners or family medicine doctors taking care of children. The teaching had been for many years to start with amoxicillin for bacterial rhinosinusitis, and as you can see here, the change has been fully made to amoxicillin clavulanic acid. This really addresses the increased frequency both of Haemophilus influenza in sinus infection as well as Staphylococcus aureus, which will often, in MSSA, require the beta-lactamase inhibitor for amoxicillin to be effective. When we look at initial regimens for second-line therapy here, I want to emphasize that initial therapy begins with amoxicillin clavulanic acid at high dosing. If you remember the slide from the acute otitis media portion of this talk, you'll note that amoxicillin clavulanic acid has superb activity against penicillin-susceptible and non-susceptible Streptococcus pneumoniae. And so it's an excellent therapy, and I would emphasize that the high dosing is facilitated by amoxiclav preparations with reduced clavulanic acid, which reduces diarrheal symptoms. So I want to emphasize that's a very useful adjunct. In patients with beta-lactam allergy, clindamycin is a useful alternative, plus cefixime or cefpodoxime, and levofloxacin is an appropriate, although not highly recommended, alternative therapy for children who have ABR. If you have a risk for failure, we would start with amoxiclav or clindamycin as a starting, and severe infections, ampicillin sulbactam is really, I think, the primary medication that we'll use for children with complicated disease requiring intravenous therapy. When we extend the table where we looked at first or second-line antimicrobial therapy and look at follow-up care, you can see here that if you have improvement on either regimen after 3 to 5 days, we want to complete either 5 to 7 days with first-line therapy or 7 to 10 days with second-line therapy, presuming that the resistance here requires slightly longer therapy. However, if there's worsening, we do want to broaden coverage or switch to a different antimicrobial class, and you can refer to the previous slide for suggestions on that. If you see improvement again, you want to complete 5 to 7 or 7 to 10 days of therapy, depending on resistance or no resistance being likely to be present. But if there's worsening here, you're really going to want specialists to be involved. CT has a role here that's important to investigate non-infectious or suppurative complications, and sinus or meatal cultures for pathogen-specific therapy may be recommended. One thing I will emphasize, the use of plain radiology in the diagnosis or the further investigation of sinus disease is not recommended. CT imaging is by far and away our primary modality, and if you're dealing with an infection that's this bad, I think the use of ear, nose, and throat physicians or pediatric infectious disease specialists is probably quite reasonable. Finally, I want to end with a last case that's a case near and dear to the eastern United States and very common at our hospital in an epidemic fashion in the last 10 years. This is a case of a 16-year-old male coming to an urgent care in your area with left knee swelling happening in February. And as you can see on the picture here, it's knee swelling that's much more suprapatellar with impressive effusion. And this is a patient who, the adolescent would probably retain reasonable mobility of the knee, complained of a little of pain, but you'll note very little tenderness and very little redness. And the patient, when you ask a good history and go back the previous year, notes that a ring-like rash had appeared the previous spring after a hiking trip in central Pennsylvania. So back in April or May, if the child was hiking in the Appalachian mountain areas, they may have noticed a little ring-like rash that perhaps they dismissed as ringworm, which is a common masquerader that we hear about. But your index of suspicion is high, knowing things, and you suspect a tick-borne illness, and that's an appropriate thing to suspect. Because when we think about Lyme arthritis, which this is a typical presentation of, you can see that Lyme disease in the United States is a fairly geographic disease, but it's starting to make some move. Lyme in 2012 in the U.S. has moved very heavily into our area in western Pennsylvania, is moving down the Atlantic coast along the Appalachian Mountains, and significantly here in western PA has actually crossed over the Appalachian Mountain chain out of its previous home base of the Atlantic coast in New England. We also see significant numbers of cases of Lyme disease in Wisconsin as well as Minnesota, and so the upper Midwest is not an unusual place to see Lyme. The development of Lyme disease symptoms is quite stereotyped, and it's quite helpful in diagnosis. Early on, after the initial tick bite, you can see an erythema migrans rash accompanied by some constitutional symptoms. And if untreated, it will then progress to more disseminated disease. Disseminated disease with Lyme disease can involve a single or multiple erythema migrans rashes. It can also involve carditis, with heart block being the most common presentation. And then we see a ton of cranial nerve palsies. And in fact, in the summertime in western Pennsylvania and in endemic areas, facial nerve palsies are most likely Lyme disease until proven otherwise. We will also see a number of patients with meningitis and aseptic meningitis that tends to have a longer duration of headache before presentation, or even a septic-like arthritis that shows up as Lyme disease. Then finally, if untreated, the more chronic mono or oligoarthritis that the patient we're seeing in case 7 has is the most common presentation, whereas the other manifestations in children, skin disease or significant neurologic disease, are very uncommon. We certainly know that the progression of Lyme disease also helps guide progression of Lyme disease testing. When you have patients who have Lyme disease, the one thing we would emphasize is don't test them in the early stage if you're looking at an isolated erythema migrans. 85 to 90% of these patients will have a negative ELISA and Western blot. And so if you make a diagnosis of clinical Lyme disease early on, you're done. You've made your diagnosis. You should report the case to the CDC, and you should treat the patient. Whereas an untreated patient then will progress to the disseminated stage 1 to 6 months after a tick bite. And this is a time when testing is very reasonable. 40 to 50% of acute sera are positive with multiple EM, and that rises as high as 75 to 80% based on a good study by Alan Steer in 2008. And 90 to 100% of patients with CNS or cardiac involvement will have acutely positive sera, with an average of 7 of 10 of IgG bands. Clinical diagnosis and suspicion is still important here, but the test is much more reliable. And untreated patients who then progress after the 6-month mark to chronic Lyme, testing is 100% reliable. We really think there's no such thing as seronegative Lyme disease in the chronic stage. These patients have strongly positive sera, and work that's been done in my laboratory and others, it really screams off of the Western blot with an average of 9 of 10 IgG bands. Clinical diagnosis is still important here, mostly to try to sort out patients who have been told they have chronic Lyme disease with no laboratory evidence, who you'll want to get out of your office immediately, as they probably need to be seen by a number of other specialists, perhaps even rheumatologists. When we think about management, the diagnosis of early disease, as I said, don't test and make a clinical diagnosis, but for treatment, we really want shorter durations of therapy. 14 days of therapy is adequate for almost all of these cases, using amoxicillin for younger children and doxycycline for greater than 8-year-olds. Cefuroxime is a backup, as well as doxycycline for allergic ones, and I will emphasize their macrolides do not play a role in the treatment of early Lyme disease. Disseminated disease, such as a facial nerve palsy or carditis or multiple erythema migrans, does require testing, I think, to confirm. Clinical diagnosis is also important, and in almost all of these patients, I would obtain an EKG to screen for AV block, given some recent reports from CDC of more severe outcomes in these cases. Treatment here is longer, and treatment, if you read treatment guidelines from the IDSA and AAP, the range of therapies are all over the place, from 10 to 14 to 21 or 28 days. I'll generally err on the side of a longer course, 28 days, if for nothing other than simplicity for most of these patients for their management. Again, amoxicillin for less than 8-year-olds is indicated, and doxycycline for the older cases. And IV therapy is a question I get asked very frequently about which patients deserve IV therapy. And IV therapy, I think, is really reserved for higher grade carditis and for early treatment of meningitis, but almost all other Lyme patients can be managed with oral therapy as an outpatient. And then finally, among patients with chronic disease, when you make a diagnosis, use testing. Testing is very reliable in these cases. It should be positive in all cases. If you have a diagnosis that's based on a negative ELISA and Western blot in any patient that has chronic symptoms, it's not Lyme disease. You really need to look for another cause, autoimmune or otherwise. And this is really the only stage where Lyme PCR has a role, being usable on joint fluid alone. I don't recommend it for use on CSF. And then finally, treatment here is always 28 days of therapy, and oral therapy is the IDSA, CDC, and AAP approved foundation of therapy for Lyme disease in all patients with chronic disease or arthritis. Amoxicillin or doxycycline, as before, it certainly has a role, but IV therapy does not have a role. Really, only in resistant disease would I consider using IV therapy, not for a first episode. And if you're worried about making a diagnosis, you could consider in a patient, as we saw earlier, with a large joint effusion and a joint aspiration, which would be diagnostic and therapeutic in that patient. And that brings me to the end of my discussion. I want to thank you for your time today. And in summary, as I've shown you in the 7 cases previous to this, pediatric diseases span a large spectrum, but the cases that we discussed today, including acute otitis media, pneumonia, strep pharyngitis, urinary tract infection, MRSA skin disease and abscesses, Lyme disease, and finally acute bacterial rhinosinusitis, are all very common diseases, and when added up together, will probably form the vast majority of the cases that you'll see in a clinical setting. Evidence-based guidelines for each of these infections are available and can guide the therapy that you'll choose for these common infections. And evidence-based guidelines are also quite useful in order for you to find those occasions when a complex patient is in your office who may require further management or consultation for you to effectively treat them. And I'll, of course, put in a plug for the use of your local pediatric infectious disease specialist to be able to help you with the particularly challenging case when you're dealing with pediatric infections. I want to thank you for your time today, and